Well, ladies and gentlemen, it's my very great pleasure to welcome you to this year's Garfield Symposium, where over the next 90 minutes we're going to have the opportunity to explore data from the Garfield AF registry. Before doing so, I'd like to introduce my co-chairman, Professor Jean-Pierre Basson, and of course, as they come to present, we will introduce to each of the faculty who are steering committee members for the Garfield AF programme. There are a few housekeeping points I'd like to make at the outset. First of all, please don't take any photographs. It's against the ESC rules. These data will eventually all be published and will also be available on various websites so that you can review these presentations. We hope to have some opportunity for questions at the end of the symposium, but if not, you could put your questions to the Garfield AF website. I would also like to make you aware of my personal disclosures here. These are the organisations, companies that I've worked with. And I must also point out at this stage that the Garfield AF programme is supported through an unrestricted educational grant to the Thrombosis Research Institute and supervised by our independent steering committee. Now, of course, Garfield is an outcomes registry. And as this is the year in which we're now starting to release not only 1 year but 2-year outcome data, I thought it's useful for us to rehearse the differences and the different purposes between randomized clinical controlled trials and real-life studies such as Garfield. And they're summarized principally on this slide. And I think it's important to understand these distinctions because the two methodologies have different purposes, and taken in context and taken together, the data generated from both randomized trials and large observational data sets helps us to understand how best to apply innovation in routine clinical practice, to generate hypotheses for future research, and to ensure that the important numbers of patients who quite rightly are excluded from randomized clinical control trials can be evaluated in an objective and prospective fashion with regard to their exposure to different therapeutic interventions. Now, of course, Garfield is not the only registry ongoing at the moment for patients with atrial fibrillation, and a number of the important registries are summarized here. And I make this point in this slide simply to be clear that even amongst registries, there are different methodologies and different designs. And of course, Garfield has a specific design, looking at newly diagnosed AF patients within 6 weeks of their diagnosis, following them prospectively for a minimum of 2 and potentially up to 8 years across 5 sequential cohorts. Other registries have a different period of diagnosed AF prior to inclusion in the registry. And of course, some registries use pre-existing risk scores, such as CHADS-VASc, as an entry trigger, whereas Garfield has just taken patients with AF where the investigator entering the individual into the registry was of the view that there was a risk factor for stroke. Garfield is the largest prospective registry in the world, and you can see the unique design features in this slide. 5 sequential cohorts, the first cohort starting at the end of 2009, and subsequently over time, we have now just, at the beginning of this month, started recruitment to the final cohort, cohort 5, which should complete recruitment by July of next year. Another important feature of Garfield has been the attempt across 35 countries to randomly select sites and then to include newly diagnosed consecutive patients at each site participating, to use different care settings according to practice across the countries, and of course to apply a high standard of data quality using 20% source data verification across the 5 cohorts. And our status currently, as of last week, was 45,386 patients across 35 countries, the blue colour countries in this slide. So it is a truly global registry as best we have been able to create it. I'm deeply grateful and indebted to all the participants, investigators, coordinators, steering committee members, and our sponsor, Bayer Healthcare, for having made this possible. And what have we seen? Well, Garfield is exciting because of its design, sequential cohorts. we can track changes in patterns of clinical practice. And here, if you look at the evolution of baseline treatment, you'll see more of these data in the presentation from Professor Cam shortly. You can see, going back to 2010-11, cohort 1, where about 4% of patients were on an anticoagulant that was not a vitamin K antagonist, some 57% of patients overall in that cohort having a form of oral anticoagulation, increasing in cohort 4, 2014-15 inclusion, to some 37% of patients now receiving one of the new non-vitamin K oral anticoagulants, and some 71% of the entire population of newly diagnosed AF patients at baseline receiving some form of anticoagulation. So we can see substantial changes in patterns of practice. But what's very exciting also in this very large registry are to look for the first time at 2-year outcomes in newly diagnosed AF patients who have been prospectively followed. And what you can see over here is that over the 2 years, if you look at the rate per person year, for stroke, 1.25%, major bleeding, 0.7%, and all-cause mortality, 3.8%, that mortality remains the largest burden for patients with newly diagnosed atrial fibrillation. And if you look over the first 12 months, the rates are slightly higher, falling slightly between months 13 to 24, but still showing that same characteristic of death being the most important burden of disease that these patients experience early in their natural history after diagnosis with AF. And we'll see more of these data and the causes of death in Professor Basson's talk. So we have laid out some important questions that we would like to try and answer today with regard to long-term outcomes, the impact of ethnicity and gender, the impact of comorbidities, particularly those not included in current risk scores, and the impact of effective anticoagulant management on clinical outcomes. You're going to see data from a number of analyses in this symposium, some 17,000 patients who have been followed for at least 2 years, some 29,000 patients with data at 1 year of follow-up, and just under 40,000 patients where we have data just of baseline characteristics.